Welcome to Leveling Up Primary Biliary Cholangitis, Optimizing Biomarker Surveillance, Addressing PBC-related Pruritus, and Application of Real-World Evidence. My name is Dr. Atusa Rabi. I'm joined today by two of my colleagues, Dr. Hannah Blaney, MD, MPH, Transplant Hepatology Fellow from MedStar Health, Georgetown University, as well as Dr. Anahita Rabi, MD, MHS, who is a transplant hepatology from Digestive Disease Section, Yale School of Medicine. For full relevant financial disclosure information, please see the iridium.com landing page for this activity. This is supported by an independent educational grant from Intercept Pharmaceutical. We would like to thank them for their support for this initiative. The learning objective for today's program are assess the role of biomarker monitoring in PBC, recognize the role of pharmacologic and non-pharmacologic management strategy for PBC-related pruritus. Hannah, can you give us a brief summary of the role of biomarkers in the management of PBC? What are the most common biomarkers that are used?
Biomarkers play a key role in the management of PBC. So we look at our liver-associated enzymes primarily. We know that alkaline phosphatase and bilirubin levels are associated with deep disease progression, with the ultimate goal of being a significant reduction, if not normalization, of these two indices with treatment. We specifically use these markers to assess the response to UDCA and determine eligibility for second-line therapies. Transaminases should also be followed. While these can be mildly elevated in inadequately treated PBC, if they are elevated above 5 times the upper limit of normal, this should prompt the clinician to consider a diagnosis of PBC autoimmune hepatitis overlap syndrome. Albumin should also be assessed along with platelet count, as these may be signs indicating the development of cirrhosis and portal hypertension. Sometimes we will have a patient with a negative AMA, however, an increased alkaline phosphatase level. These patients should have their biomarkers monitored at least yearly. In patients where we have a high suspicion clinically of PBC, we can consider ordering PBC-specific ANA serology, including anti-GP 210 and anti-SP 100. We should order these if available, or we could consider a liver biopsy to help us assist with a diagnosis of AMA negative PBC. AMA negative PBC really has a similar disease course as well as a response to treatment as what we see with AMA positive PBC. In patients with AMA positivity, however, with normal liver-associated enzymes, these patients may have an increased risk of developing PBC. There's one study that showed that about 16% of these patients progress to PBC within 5 years. As such, these patients are at high risk of developing PBC, and they should be followed more closely with assessment of liver-associated enzymes every 6 to 12 months.
Anahita, how does biomarker monitoring fit into the new treatment algorithms for PBC?
That's a great question. So I'm going to go over the new treatment algorithm, and we'll kind of put where biomarkers come in. Once a diagnosis of PBC is confirmed, you first want to stage the degree of fibrosis in these patients. And it is best done by transient elastography or an MR elastography. Basically, you start them on treatment with UDCA. It's the first line treatment. And it's weight-based, 13 to 15 milligram per kilogram per day. And around at the same time, you want to stage their fibrosis. So you either get transient elastography or MR elastography. If the transient elastography is less than 10 or the MRE is less than 4 kilopascal, that means that the patient does not have advanced fibrosis. So you have a little bit of more time to monitor the patient and see if they're responding to UDCA. However, if the patient has evidence of advanced fibrosis and, with the transient elastography being 10 or above, you want to go back and make sure that they're responding sooner. So basically at 6 months, you want to evaluate treatment response. And the treatment response would be at 6 months. the alkaline phosphatase being less than 1.9 upper limit of normal, plus the bilirubin being less than upper limit of normal. And at 12 months, it would be alkaline phosphatase being less than 1.5 upper limit of normal, plus bilirubin being less than upper limit of normal. So if they are responding based on these criteria, you continue the same treatment and you monitor bilirubin and alkaline phosphatase every 3 to 6 months. However, if the patient is not responding to this treatment, or for whatever reason the patient is intolerant of UDCA, you want to think about second agents. One part of the algorithm that comes into play here is if the patient has evidence of clinically significant portal hypertension or has decompensations, you want to consider referral for liver transplant early on. So going into basically second-line treatments, you can start the patient on obeticholic acid. Usually it's started at 5 milligrams once a day, and you can increase it to 10 milligrams after 3 months if the patient is able to tolerate the dose. Or you can consider off-label use of fenofibrate. Usually it's started at a low dose of 45 milligrams per day, and it can be titrated up again based on tolerance. And you want to assess alkaline phosphatase and bilirubin at 3 to 6 months to see if they're responding. And response criteria would be alkaline phosphatase being less than 1.5 upper limit of normal and bilirubin being less than upper limit of normal. However, if they are not responding to this treatment, or specifically in the case of obeticholic acid, patient is intolerant because it can cause a lot of pruritus, you want to consider another second-line therapy, or so basically you can switch, or you can consider doing a triple therapy, basically having the patient on UDCA, obeticholic acid, and fenofibrate. You might recognize that elafibranor is not included in this algorithm. This was very recently approved about a month ago, and I'm sure in the future it will make its way to the algorithm, but currently it's kind of hot off the press, so it's still not included in this algorithm as a second-line therapy.
So now let's talk about PBC-related pruritus. This obviously significantly impacts the lives of patients with PBC. To manage the symptom effectively not only means improved patient comfort, but also it enhances patients' overall treatment adherence and quality of life. Can you give us an overview of what kind of impact can pruritus have on patients' quality of life and what it would mean for treatment adherence?
Pruritus is one of the most common symptoms of PBC. Up to 75% of patients with PBC will experience pruritus. So pruritus has been shown to negatively impact quality of life, including contributing to fatigue, depression, sleep disturbance, as well as social life interference. It can be really frustrating for patients and then providers alike for treating these patients. So unfortunately, ursodeoxycholic acid, or UDCA, does not improve pruritus, and in rare incidences can actually worsen pruritus. Our second-line agent of obeticholic acid, while it's a great medication for the treatment of PBC, it can actually induce or intensify pruritus in about 40% of patients. There are some of the PPAR agonists, the newer medications that are being studied, including elafibranor as well as the fibrates. And then there's some other agents that are currently under study that do seem to significantly reduce cholestatic pruritus. Hopefully we'll have some new options for these patients in the near future.
Thank you, Hannah. Anahita, can you provide us with some strategy for managing pruritus, both pharmacological and non-pharmacological approaches? Specifically to manage dose-dependent pruritus in patients who are treated with obeticholic acid, and how you recommend that the physicians adjust the dose based on the patient's pruritus symptoms.
Good question. So in terms of the pruritus, one of the first-line medications that we use is Colestyramine, and it can be helpful in many patients. Other medications that we use that are generally off-label include rifampin, naltrexone, sertraline, and bezafibrate. There are also non-pharmacological treatments such as skin care, phototherapy, and severe cases we can even think about albumin dialysis, plasmapheresis, and biliary drainage. In terms of the medication management, specifically obeticholic acid is important because this is a medication that can result in severe pruritus in many patients treated with this, and one of the main reasons for discontinuation of treatment. So basically, if the patient has moderate pruritus and you are at 5 milligram dose, you basically wanna either still you could consider up titrating or staying at 5 milligram. If you're already at 10 milligram, you stay at 10 milligram. And once the patient has severe pruritus, if you're at 5 milligram, you can decrease it down to 5 milligram every other day, or pause treatment temporarily for 2 weeks. And after that, again, start with the lower dose of 5 milligram. If you have severe pruritus, you're at 10 milligram, you can decrease it to 5 milligram. So basically, by adjusting or trying to reduce the dose, you see if you can have the patient be able to continue the treatment rather than completely stopping it.
Thank you. So now let's talk about the real-world evidence about management of pruritus in PBC. Can you highlight some of the key studies that have been done, and what are some highlights of the promising treatments for pruritus specifically in PBC patients?
The Target PBC trial is a large real-world US cohort that highlights the pervasive impact of pruritus in patients with PBC, as well as some of the shortcomings of the medical community's current response. So it's a 2023 study that included 211 patients with PBC, with the overall prevalence of pruritus pretty high in this population, with 81% of respondents reporting itch of any degree and 37% reporting an itch that was at least severe enough to be deemed clinically significant, using the PBC-40 scoring, which is a patient-derived validated questionnaire. So patients with clinically significant pruritus were more likely to receive treatment versus patients with just a mild itch, with 51% of patients with clinically significant itch receiving treatment versus 28% of those with mild itch. This shows us that only half of patients with PBC that with clinically significant pruritus were treated. And it really suggests the undertreatment of patients with PBC-related pruritus. Of those receiving treatment for pruritus, antihistamines were commonly prescribed for both mild, which was 73% of all patients, as well as clinically significant, including 66% of these patients, followed by bile acid binding resins, such as Colestyramine. So as the pruritus of PBC is not mediated by histamine, antihistamine therapy is really not, effective in these patients. Furthermore, antihistamines may exacerbate symptoms like fatigue, as well as sicca symptoms such as dry mouth. So these data from the study reveal that clinicians were not complying to guideline recommendations for the management of pruritus. Colestyramine is our first-line therapy for pruritus, as recommended by both ASLD and EASL, and really was not used at a high percentage in these patients. The undertreatment of pruritus in PBC could be due to several reasons, including a lack of effective current treatment options, tolerability issues, as well as difficulty in dosing, as well as the appropriate use of bile acid resins. It can be challenging for patients to time the dose with their other medications and with eating, as well as a lack of FDA-approved treatments. In another study involving 225 patients, pruritus in PBC was under-recorded in patient medical records. Pruritus of any severity was self-reported by up to 90% of patients with PBC. However, only in 31% of these patients had a recent documented pruritus in their medical record. As such, there's a big mismatch in patient-reported measures and medical records, suggesting that pruritus is really underreported in medical records. The high percentage of patients reporting pruritus despite available antipruritic treatment suggests that pruritus continues to be undertreated and undermanaged. This should remind us to always ask, document, and treat symptoms associated with PBC, like pruritus, at every patient visit. There is still a need for newer therapies to address the debilitating impact of pruritus in patients with PBC, with some exciting possible therapies in the pipeline. First, we have linerixibat, which is a ileal bile acid transporter inhibitor, which is under study for cholestatic pruritus in a Glimmer study. In the Glimmer study, which was a phase 2b trial for itching, there was a significant decrease in itch in the per protocol population. This drug is currently in the phase 3 trial. Bezafibrate, which is not available in the United States, is a pan-PPAR agonist. This medication was shown to significantly decrease pruritus in the phase 3 trial. Another medication, seladelpar, which is a PPAR delta agonist, demonstrated a significant reduction in pruritus from baseline in a recent phase 3 clinical trial. Elafibranor, which was recently approved in June of 2024 by the FDA for treatment of PBC, is an alpha and delta PPAR agonist. Elafibranor also had a reduction in moderate to severe pruritus at 52 weeks from baseline, according to scores from the PBC 40 questionnaire, as well as the 5D itch scale.
Thank you. That was great. If I may summarize this session, we rely heavily on biomarkers to monitor progression of primary biliary cholangitis and to assess the effectiveness of treatment. Unfortunately, pruritus is common, very troublesome, and can significantly impact patients' quality of life, but often doesn't receive adequate attention in treatment plan. This really underscores that we need newer, more effective treatments and including dose-dependent management strategies. We have reached the end of the program. I want to thank all my colleagues and faculty for this engaging discussion. We would also like to thank Intercept for the support of the program. Be sure to claim your CME credit by filling out the evaluation and post this. And follow Iridium on X, Facebook, and LinkedIn to see the corresponding meta threads.